I think you can probably go ahead.
I can start.
I think the sound issue is corrected now,
Yes.
if there are no objections.
No. I can start the case.
Please do.
Okay. Good afternoon, everybody. I go to start this telegram round today, and I hope you enjoy the case because this case is very recently, and unfortunately, the case is a doctor who was coming out of his hospital, and he was be injured by a gunshot wound. So it's very important to know that sometimes it's happened with doctors, and very important to know. Okay, let's go. It's a 27-year-old man. He's a cervical transfixion gunshot wound in the zone 2. At the scene, the patient has received a gunshot wound near the hospital, and then he continued with his car through the other highway, and then he called for a pre-hospital. The pre-hospital showed the patient with airways, dysphonic respiratory rate, 80 EPM, saturation, oxygen not measured, central trachea without jugular stasi. Vesicular murmur is present. Systolic pressure 170 millimeters of mercury, and cardiac rate is 188 BPM. Glasgow Coma score is 15, and pupil is choric and photoreagent. Entrance wound is on the left side, in zone 2, and exit wound on the right side in zone 2. It transfixes through this size for this size. I have a question to comment. What do you do for transfer these patients from the scene to the hospital? Airway and circulation. What do you do with this patient? Dr. Cassim?
Good morning, Dr. Collet. Obviously, this is going to be one of your best. I'm glad I got up to listen to this. So this is a trans neck gunshot wound, and we are all very familiar with transmediastinal gunshot wound. So this is a variation of that. And the first thing you ought to do in a case like this would be to see if the patient is able to verbalize. Ask him his name to see if he can talk. If he can talk and respond appropriately, then you know that his airway is intact. And sometimes you might get a false impression from this. You know, he might be able to say one or two words, but it doesn't mean that his phonation is quite adequate to maintain the airway. So in a situation like this, when the patient is not bleeding externally, profuse amount of blood, airway is the prime factor that is going to determine whether this patient makes it or not. So you need to attend to the airway. And if you have to intubate a patient like that, and I think you should be a little cautious, but not too cautious that you allow him to go into respiratory arrest. Thank you.
Doctor? Please, I don't remember the names of all of them. I think there is some. Antonio, you are here? No.
Maybe Dr. Metagozo is here. He can moderate again.
Dr. Carlos?
He seems to be having problems with his mic. They're all working on it
muted.
right now. That's why they're not able to do it.
Okay.
Sorry.
The name.
Could I help you? Could I help you, Dr. Collet?
Yes, please, Dr. Kassim.
Okay. Dr. Untrak, go ahead, chime in and tell
Yes,
us what you would do.
Sure, I agree with what Dr. Kassim said. And, you know, in this case on paper, all the signs look good. He was struck by a bullet in the parking lot of the hospital, started driving and then called for an ambulance when he realized what happened. And Glasgow Coma Scale of 15 suggests that he's responding appropriately, that he's breathing, that the bullet didn't strike his cervical spinal vertebral column and cause brain death. So that, you know, all those signs are good. So, and I would want to see on physical exam, does he have any hard signs of airway injury or vascular injury? It sounds like he doesn't. And in this case, I would probably just put 1 or 2 IVs in, you know, and if his airway is okay, and he's not too far from the hospital, get him back to the hospital. And as Dr. Kassim said, be prepared to intubate him, get an airway if you need to, you know, if you lose the airway. So, you know, in this case, it seems like you're ahead. If he survived the initial minute or two, you know, things are looking good.
Okay. There is some other.
There is a gentleman from the Army, are you Major Colonel or Colonel O'Connell? Mr. O'Connell, would you like to chime in? You're muted. No.
No.
You can get to us. Well, we have problems with the audio this week, so we will move on to Dr. Collet.
Okay. What's happening with this patient? Is the pre-hospital?
Can you hear me?
Yeah. Yeah.
Yes.
Okay,
Yes.
they've let me speak.
Oh, good.
Good. Good.
I guess I would agree with the two first people who commented in. There's some good things and some bad things. The fact that he's alive at all is very good and able to so reason for optimism. His dysphonia and I think it mentioned a vascular bruit or something. Those are hard indications for immediate exploration. I guess in the pre-hospital setting, the airway is the most important thing. There's a variety of ways you could approach that. I would agree that starting with an endotracheal intubation is probably the way to go, but I would have a very low threshold if there was any problems to do, if the medics are able to do a cricothyroidotomy. Then getting control of bleeding doesn't sound like it's a problem, but that could probably be accomplished with some pressure. So yeah, I would say secure the airway if needed, control bleeding, and get to the hospital without too much delay.
Oi,
Thank you.
pode ser pouco.
Pode servir?
Pode.
Arroz, feijão e bife.
Well,
Tá bom. É que bife é duro pro meu dente, eu
Tá
prefiro
bem,
ovo.
Lucio?
let's go to continue the case. The patient, the pre-hospital team decided to intubate the patient because the transportation for the hospital, for other hospitals, not the hospital the patient was working, is not adequate for trauma assistance. They decide to make intubation, sedate intubation. It starts with saline, and the pre-hospital care and transportation was around 45 minutes. The patients arrived in the hospital. He was intubated, sedated, machine ventilation, respiratory rate is 18 EPM, saturation is 100%. He has a subcutaneous emphysema on the chest and the neck. Bilateral decreased breath, noisy. Systolic pressure 160 by 107 millimeters of mercury. Cardiac rate is 94 BPM. Glasgow Coma score, the patient was sedated, was 3T, hydrochloric and photoreagent. Entrance wound on the left side in zona 2, and exit wound on the right side in zona 2. Here you can see the exit wound. Here, the other side is the entrance wound. It's not easy intubation for this patient in the scene. His lab exams, yours, pH 7.3, PO2 100 millimeters of mercury, PCO2 40 millimeters of mercury, bicarbonate 20, BXSS minus 45, lactate is 19 millimeters of deciliter. Hemoglobin is normal, the others is normal. What to do with patients now?
Dr. Untrak, would you like to go?
So the lactate of 19, what's your normal upper limit of normal there?
What?
Dr. Collet, for the lactate, the upper limit of normal?
Yes,
It's 14, Dr. Untracht.
14.
Oh, 14. Okay. So yeah. So he needs to be resuscitated. He's a little acidotic, and lactate is a bit high. White count is up, so he needs a little bit of fluid, Foley catheter, and at this stage, I think it would be reasonable, because his blood pressure is actually hypertensive. While he's being resuscitated, you might consider doing an evaluation. So CT scan of the head and neck and chest, and perhaps upper GI endoscopy to look for injury to the esophagus. And the CT scan with CT angiography would assess for a vascular injury. But I would consider doing those studies before exploring the neck.
Dr. Kassim, what about you? What do you think about the case? You're muted, Dr. Kassim.
Okay. It looks like he's stable, and he has an obvious injury on the left side of the neck, which is traversing and exiting on the right side. There are three structures that I would be worried about. Obviously, a vascular injury. If there is a vascular injury, he should have some evidence of some bleeding externally. So far, we have not seen that. And we have not seen any appreciable hematoma, even though he's got a very thick, fat neck. And like Dr. Collet said, the intubation on a patient like this is as hard as it comes. So be that may, there are two other structures that are involved here, trachea and the esophagus. Before you send the patient for CT scan, from physical examination, Dr. Collet tells us he's got subcutaneous emphysema. So I would be very suspicious he has either a tracheal injury in the back of the trachea or esophageal injury around the esophagus somewhere. So it won't be very difficult for me to put a endoscope via the endotracheal tube to at least have a look at the trachea to see what it looks like, if there is any obvious tear in the trachea. And following that, it shouldn't be very hard also to slip in a gastroscope or esophagoscope to have a look at the esophagus, at least in the upper third of the esophagus, to see if there is any obvious injury. Having determined that, then I probably would like to resort to a CT of the neck and the chest to see if there is anything I can determine before I embark on taking the patient to the operating room for definitive repair. Thank you.
It's great. That's great. So I'm going to take over the moderation now to help Dr. Collet.
Thank you.
Yeah, thanks. So I'm going to ask for some more opinions here from the other panelists as well. And Dr. Lenin, are you joining the? Did you get all the case? Would you like to make any comments about the case?
Yeah, I heard it so far. I mean, it's, I think transport time's like 45 minutes, so he survived this long. I don't think I think you can get a lot of information from a CAT scan with an injury like this. So, and he's pretty stable, so I would get a CT angio of his neck and see what's going on there. I mean, some of these we've seen like these miracle bullets that somehow miss everything, but it'll give you a landmark of what to do if you need to go to the operating room. And with some of the interventional and endovascular things nowadays, some of these things maybe can be used. So I would get a CTA on this patient.
Excellent. Thank you very much. And I saw that Dr. Kaufman was initially chatting with us in the beginning. Dr. Kaufman, are you there? Do you want to make any comments? Do you agree with the other panelists?
Thank you for asking. I agree with everything that's been said before. I appreciate it though.
Awesome. Nice to hear from you again. Dr. Brian, do you want to make additional comments?
It sounds good. He's stable enough for a CTA. Some of the things that he presented with the dysphonia, sub-Q emphysema, and again, I think it was mention of a vascular bruit, plus the fact that this case is being presented at all leads me to believe that there's something operative with this case. But I agree. You can wait for a CTA. Probably the patient will be okay.
Excellent. So I think that we covered all the aspects until now. Dr. Collet, I guess you can move on.
Okay. Here you can see the CT. Here I go to the Brian, there is no injury. Sometimes you can see emphysema, subcutaneous emphysema on the head. I can go down, can see more emphysema, subcutaneous emphysema. Here you can see the emphysema. It's very big emphysema. When you go down, the suspicions on the cricoid cartilage may be an injury. And continue. I go to show all the CT. Go to the chest, can see the very big emphysema, subcutaneous emphysema. Mediastinal emphysema. When you put the contrast, you can see now show no arterial injury in the neck. The carotid vertebral veins was normal. There is no signs of injury. So we have a big emphysema, a suspicion of injury of the tracheal injury or cricoid injury. And at this moment, let's continue to show. Here the reconstruction. You can see the vessels was normal. And then the reconstruction of the vessels. Can see here. Here. Can see the reconstruction with subtraction. There is no vessel injury in the patient. Let's continue. on the chest, you can see a very big emphysema, a pneumothorax on the right chest, a small pneumothorax on the left chest, but you have a big emphysema, emphysema mediastinal emphysema. You can see. Here the reconstruction cranial, reconstruction. You have some signs of aspiration and pneumothorax. Here the reconstruction. You can see there is no signs of vascular injury. What to do next?
That's great. So I think summing up the CT scan findings, it seems that there are no vascular injuries, at least no important vascular injuries, and there's a suspicion of a cricoid injury. Is that correct, Dr. Collet?
Yes.
Okay. So let's start this time with Dr. Lenin. So would you take this patient to the OR? Would you do a non-operative management? What would you do?
Well, I mean, you have a small cricoid injury. I mean, these things usually fix themselves, but this is guy's got massive subcutaneous emphysema. He's got a pneumothorax, which he's going to require a chest tube for. I would, worry. You don't really, even though you may suspect the cricoid or whatever, you can't really tell based on that CAT scan where the injury is for sure. There's a lot of there's a lot of edema in the larynx on that CAT scan.
Yeah.
And you don't want to pull back that ET tube to get a look like too far and lose your airway. So I would probably explore this guy's neck and looking for, a tracheoesophageal injury in that area. And I guess the next question is how are you going to approach how are you going to approach this, either through a neck incision or a collar incision, or are you going to complete that and flap the whole thing up? I think that's, I think you can start with one side and see what you get, and then you can extend over and flap everything up if you have to. But I would probably start with like a right neck dissection to start, and then I can always extend onto the left and flap everything up if I have to.
Awesome, thank you. Dr. Brian, would you agree? Would you operate or would you do a non-operative treatment?
Yeah, I definitely operate. That's what the all the CPGs and the guidelines are. If you have an aerodigestive injury, then you should operate. I think if the injury is at the level that you said, that it's lucky for the patient, because if it turns out to be as you've described it, then you can always trach the patient below, probably an easy trach if the injury is high. So that's a fortunate thing. And then I would say, yeah, you have to absolutely be very cautious and look for an esophageal injury. So you really want to inspect and mobilize everything, because if you miss that, the patient's going to do horribly.
Excellent, thank you. Dr. Untracht, do you see any roles for non-operative management here, considering this?
No, yes, in this case, I agree with the other comments. I would take him to the operating room before making an incision. I would look with an endoscope to look for hypopharyngeal or upper esophageal, cervical esophageal injury. And I think you can rule it out that way. I mean, you get a very good look at the mucosa, and if there's no digestive tract injury or hypopharynx injury, then it's, as the CT suggests, coming from the trachea or the cricoid cartilage, the lower larynx. And then I would explore the neck as if you're doing a tracheostomy. So a low collar incision may be extended slightly, and then explore and see where the defect is, and if it's at the cricoid cartilage level. And as Dr. Lenine said, I would put the standard tracheostomy tube. That should control the air leak, and then a narrow caliber chest tube on the right side, and then within a day or two, the subcutaneous emphysema should just resolve. So I would approach it that way.
Excellent, thank you. Dr. Kassim, do you agree? And also, can you comment on the pneumothorax on the right? What was the cause? Is that like a trajectory? What happened? What do you think happened?
I agree with Dr. Untrak. I would use the endoscope to the full advantage. I would do tracheal endoscopy to see if there is any evidence that I can determine to help me with further management. And while I'm there, I would also slip in the esophagoscope to have a look to make sure that the esophagus is not the culprit in this. I'm suspicious the patient has two injuries here, tracheal injury plus esophageal injury. The pneumothorax on the right side is probably tracking from the esophagus or the trachea into the chest area. And because he also has pneumomediastinum, and I would just simply put in a chest tube on the right side. The left one seemed to be fairly small. I will watch it to prevent any tension pneumothorax at the later end. Now, what would I do in a case like this? I think I would start with doing a below cricoid conventional tracheostomy, so I get full control of the airway in case I lose the airway one way or the other afterwards. Once I have that under control, then I am at the leisure to see what I want to do with the tracheal injury. And I can also mobilize the esophagus from above, all the way from the pharynx to the inlet of the thorax, and have a good look at it, make sure no nerves are injured there as well while I'm doing that. And then I can make a determination what type of repair I am going to do after I have identified the type of injury that I am seeing and directly under direct vision. Thank you.
Great, awesome. So I think we have a lot of opinions here, and this last comment about the tracheostomy. So Dr. Kassim would do a tracheostomy first and explore afterwards, and the other panelists would do the exploration first and then decide. So I guess you can continue, Dr. Collet.
Okay. Here we decide to make a bronchoscopy and endoscopy previous for the surgery. Here you can see the bronchoscopy. Here you can see an injury. It is 4 centimeters below the vocal cords. Explosion of the cartilage of the first rings of the trachea, and the cricoid anterolateral injury. You can see the bronchioles. There is no other injuries here. Some blood in the bronchioles and segments of the lung was aspirated, probably during the intubation in the field. No injuries see in the endoscopy. Here you can see again. It's very interesting because you can see here the injury of the trachea. It's a very big injury through the bronchoscopy, and to treat this is a very difficult sometimes. I put a chest tube on the right side. And I got then what incision? I have two questions. What incision to treat this? Which incision? And tracheostomy, primary repair and tracheostomy. What to do to repair this injury? How you manage this injury? I think is very important because the injuries is involve cricoid and trachea.
Okay, so Dr. Untrak, do you want to comment on these questions?
Yes, I had a little difficulty appreciating exactly where the injury was looking at the photos, but you say it's 4 to 5 centimeters distal to the vocal cords. That's about where a tracheostomy tube would go. It's like 3 or 4 rings down. So you say, but is it just down at that location or continuously from the cricoid cartilage down 4 to 5 centimeters?
No, it was not continuous from the cartilage to 4 or 5 centimeters. It was only at 4 or 5 centimeters from the cricoid.
Right, and then also the cricoid cartilage was injured as well, was also damaged. So, but anyway, I think it's reasonable to explore as if you're doing, anterior collar incision and look at the injury. If it's right where you would put a tracheostomy tube, you can put a tracheostomy tube through the injury. And but if you try to do a simple direct repair, it's likely to get a stricture that will need to be dealt with later. And if you feel comfortable doing a primary repair, the way Hermes Grillo used to do these was just to excise the stricture and do an anastomosis of the trachea to trachea, and then wrap it with omentum, and usually bring the omentum up from mobilize the omentum in the abdomen, bring it up, and then wrap the repair. But I would at this point you're winning. You have control of the airway. You have a patient's intubated, and unless it's all but a trivial wound that you can put a tracheostomy tube in, I think probably the best expert with a trachea, and that's probably you, Dr. Collet, should deal with it. So I think it's reasonable to explore, see what you have, and then realize that right now you're ahead by having a tube beyond the area of the injury. So, there's a little bit of risk by being more aggressive in this case.
Excellent. Dr. Lenin, would you like to comment on the options?
I mean, I kind of agree with Dr. Untrak said. I mean, you really have to see what the injury looks like. I mean, and where it really is before you can decide what to do with this. If it's a small hole and there's not a lot of devitalized tissue, you can just put the trach in the hole. But based on that, I mean, it's a little deceptive, but based on the endoscopy, it could be pretty extensive. And then you may end up with a stricture, even with a tracheostomy, and it'll be left with a tracheostomy. So I think you have to see what it looks like in the operating room, see what you have to debride, and make sure there's not a hole that you're missing posteriorly with esophagus.
Great, thank you. Dr. Brian, any additional comments?
I agree. You have to take a look and see what's fixable. I think a gunshot wound is going to be more destructive than a stab wound. So I would be a little bit worried that things are not going to come together. But my understanding, my limited experience with dealing with injuries is that the trachea can be very forgiving and that the patient might do well with kind of any of those options, a primary repair and a tracheostomy, or just inserting a tube directly into the wound. If I did repair it, and it looked like it was not, if it was very destructive, then I would think about buttressing it with trying to maybe rotate some muscle into it. And I agree with Dr. Lenine, if it's wide open, it's very important to look at the posterior aspect to make sure it didn't go into the esophagus, but I agree with everybody else so far.
Excellent. Dr. Kassim, also want to know about your comments and what kind of approach would you recommend for everyone to explore the posterior parts of the trachea to make sure you're not missing an esophageal injury?
I have attended Dr. Hermes Grillo's lectures at Mass General a couple of times in my career. And every time that I go and listen to him, it is a treat, because this is not something that most surgeons familiar with. This is the tiger country in the neck, so as tiger country around the gallbladder as well. So I think the thing that I learned from him is not to put a tube through the hole following a gunshot wound, because it invariably causes strictures and other complications later on in life, and then you have to deal with. So I would avoid putting tracheostomy through the hole, or any type of foreign material through the hole. And like the Colonel mentioned, it's a gunshot wound, it's not a stab wound, and there will be reasonably extensive tissue destruction. So you have to have a plan what you're going to be doing here. And having ruled out the esophagus is intact, and you don't have to deal with the esophagus whatsoever. In my opinion, what I learned from Dr. Hermes Grillo was the best thing would be to do some type of buttress of viable tissue, neck tissues. Don't do any stitches in the trachea itself, or don't do any repair, primary repair, because they are bound to be breaking down, and slap viable tissue, i.e. strap muscles from the neck, and try to close the hole, and then get a tracheostomy below that, so that you have adequate airway and you've done your very best to close the hole with some type of a viable tissue on top of it or below it, whichever way that you're going to do this. That's what I would recommend.
So, Dr. Kassim, just to make sure I understood it correctly, you could, for example, get a muscle flap, for example, and put over the hole of the trachea, right, and do a tracheostomy below that, correct?
Below that, correct.
Okay, perfect.
Don't do any primary repair to the injured trachea itself.
Great, thank you. Okay, Dr. Collet. Oh, I'm sorry, Dr. Varon raised his hand. Do you want to make some comments?
Yeah, I don't have a comment, but I have a question from Ryder. Albert Barron is my name. I'm an anesthesiologist. So I'm interested in the airway. So it was mentioned that the patient was intubated before arrival. Is that correct? And yeah, where was the location of the tube? Was it distal to the injury or proximal to the injury?
The tube is above the injury.
It was above the injury?
Yes.
The reason I say that is because if it's above the injury and you do positive pressure ventilation, bad things will happen. Patients can collapse, patients can die basically at that point. And the ideal is to always have the tube below the level of the injury for that reason. Many of these patients die on transport because you start ventilating them above the injury, you get massive subacute emphysema, bilateral pneumothoraces. So I'm just impressed that this guy actually made it, was still alive when he arrived despite positive pressure ventilation.
Yeah, thanks for the comment, Dr. Varon. Really interesting, really insightful.
Well, just a suggestion, and we do have experience with penetrating neck injuries. as compared, we have a large series. Well, our recommendation of those patients is to intubate it and put a scope through the tube as the tube is going in, so the user can see where the tube is going. Because if this patient had an esophageal injury, even if you can see the vocal cords, once it's past the vocal cords, it can go into the esophagus, and the patient will expire. So putting a scope inside the tube as you're going in allows everybody to make sure, number one, you can do a quick view and see if the injury is actually injured. You can advance the tube just above the carina, and that would be a life-saving intervention. So in any hospital has the scope. I'm not talking about a wake bronchoscopic intubation. I'm talking you put the scope through the tube instead of putting a stylet. And as you're advancing, you can see where the tube is going. Because the question here is not, can I see the vocal cords? The question is, what the hell is below the vocal cords? Because the tube can go to the esophagus. We have seen it many times. So that is one of the risks. This patient got lucky that it didn't happen to him, and he did not have an esophageal injury.
That's really interesting, Dr. Varron. Thank you very much. Dr. Untracht, do you want to make any comments?
Yes, I think there's a little bit of a misunderstanding. I think the tip of the endotracheal tube was below the area of the injury. Those photos that Dr. Collet showed, you can see the endotracheal tube going beyond where the injury is. The bronchoscope was outside the endotracheal tube, but inside the trachea, if I'm not
Good.
Mistaken. Is correct, Dr.
Yes.
Dr.
That is
Collet?
why,
Yes.
then that's the case why the patient survived. If it was above it with some positive pressure ventilation, so the patient was lucky they have esophageal injury and that the tube was past the injury. But if the tube had gone through the injury or was above the injury, the patient would have not arrived to the hospital.
Yes.
Excellent. Thank you for your comments. Dr. Collet, I think you can proceed.
I agree with all comments. It's very important because these patients have one thing more. They put a nasogastric tube. They don't know what happened with the neck of the injury. You only put a nasogastric tube in patients with neck injuries. You can aggravate the patient. Can distamponate sometimes injuries in the neck. And I agree. When you put a tube in the tracheal injury, you can make enhance and increase the hole during the maneuvers that you can put the tube and insufflation the balloon, the cuff. So for us, you receive these patients intubated and the patient was stable, and then you go to the surgery. I decided to make a anterolateral cervicotomy and explore the neck. Here you can see the patient. I go to stop. Here is the entrance wound, the exit wound. It's in the surgery. Here I make anterolateral, left anterolateral cervicotomy. You can see sternocleidomuscle. Here's the hole in the midline. Can see the injuries across the sternocleidomastoid muscle here, and the hole open. Here's the thyroid gland. Here's the hole go through the trachea. We make incision in the isthmus of the thyroid gland, and then you can see the hole. I go to stop here to show. Oh, just a minute. Can show more here. Here you can see cricoid cartilage. In it, you can see injury of the first and the second tracheal hole. Through the hole, you can see the endotracheal tube, and the cuffs are below the injury. Here you can see. You can see the tube, the endotracheal tube, and the injury here. So at this moment, I decided to make a primary repair of the injury, debridement of the portions of the cartilage there, and then suturings. I think it's very maybe problem for intubation, for evaluation, So I decided to put a tracheostomy below. You can see. And the end of the surgery, I put here.
Okay.
Okay, I put a tracheostomy below the injury because I have problems to think about the edema, the vocal cords. If this injury is near laryngeal injury, so I believe the tracheostomy is more safety for this patient and for extubation and evaluation of the injuries of in the larynx in this patient. That's the case. That's the treatment that I made. So I want to know the comments of your comments about the surgery.
That's great. Thank you, Dr. Collet. Dr. Untracht, do you want to add something?
Yeah, beautiful case. I knew it was going to be something really spectacular when Dr. Collet presents something like this. And 27-year-old doctor, my goodness. So, you know, and this, he's still just a recent injury. And wow, then he's going to have to go back to work in the same hospital. And geez, you know, I'd be a little spooked if that were me as a young man, young doctor. But beautiful job, and you know, looking at your repair, you know, I would be hopeful that it's going to heal just fine. He won't have a stricture or any other complications, and you'll be able to decannulate him in about a month or so, and he'll be fine.
Excellent. Thank you. Dr. Brian, do you want to add some comments?
I'm glad for the patient that it worked out so well. I'm curious to hear how he got shot coming or going from work. I think that's interesting. Hopefully that doesn't happen to any of us. That's something to think about. And no, I think the operative approach was fine. I think I would do a GI endoscopy just to check or double check. Sometimes when I was at Ryder, I think the protocol was to scope and to do a GI swallow, just because neither of those techniques are 100% sensitive for an esophageal injury, which can be hard to diagnose. I'd like to hear what everybody else has to say.
Great, thank you. Dr. Kassim, do you want to make additional comments?
I totally agree with Dr. O'Connell. The protocol that he's mentioned is what I would follow and what I was taught to follow as well. And I have a question for Dr. Collet. So you saw the injury, which was anterior part of the trachea, am I correct?
Injury is anterior but lateral for the left side.
And anterolateral. So did you have to, okay. Did you have to sacrifice the cricoid at all, or did you reconstruct the cricoid?
I reconstructed the cricoid. I use the cricoid to fix the rings of tracheal rings.
Okay. And then on top of that, you put the strap muscles.
Yes. It's closer. Don't put nothing more. I think I put the tracheostomy and can be safe for protection the injuries, and when you have to decannulate, you can make a laryngoscopy and bronchoscopy before the decannulated patient. Okay.
Excellent. Well, it is exactly what Dr. Hermes Grillo would have done as well. So we have another Hermes Grillo from South America. And very well done. Very good teaching case for those of us who don't deal with this very often. And as usual, it is master surgeon at work. Thank you.
Great, thank you. Dr. Lenin, do you want to make any final comments? And also, one of the surgeons that are with us here today asked a question and I wonder if you could answer or give your opinion about it. So he's asking if you have a patient that suffers a firearm or a knife injury at level 2, zone 2 of the neck, that does not compromise the airway but is bleeding a lot, how would you compress it without compressing the airway? So if you can comment on that as well, I would appreciate.
But I missed the end of the case, so I don't know, I mean, compressing an injury, I mean, obviously you try not to compress the airway as you're compressing the injury. So if you have, if you're bleeding out of one side of the neck, you have to compress down on the vertebrae without compressing the trachea as best you can. I mean, people have used, if you have a gunshot wound hole, they've tried to use Foley's, where you put it in there, hyperinflate the Foley, put it on traction. But most of the time, I just hold pressure down onto the vertebrae without compressing the airway.
Excellent, thank you. Dr. Veron, do you want to make any final comments?
No, I agree with Dr. Lenin. We do for stab wounds. Sometimes you can do balloon tamponade with a Fogarty or with a Foley, but it's not always possible, but that's an option. And as Dr. Lenin, direct pressure with a finger seems to be the most effective with trying to compress the airway.
Yeah.
I just want to make a point that when you have a tube in place, I don't know how they bronch him later. If the tube is past the injury and you put a scope through the tube, you won't be able to see a thing unless you take the tube out or try to get it on this side. So that's also challenging to be able to visualize the injury once the tube is past the injury.
Yeah. Okay, thanks a lot. Thank you for the comments. It's always nice to have a lot of different specialists in the gathering as well. So, Dr. Collet, there are some questions for you if you want to answer them here. So, Dr. Flavia is asking you if dividing the neck in zones in this case actually made any difference in your approach or not. Would you like to answer that?
If you divide the zones, no, there is no problem. But the great problem when in zone 2 is very easy to see. When you go to zone 3 or 1, it's very difficult. Sometimes maybe different approach. So can associate some other incisions to approach. But I think the zones is only to classification the injuries and can see the zones can be facilitated to know where is the injury. Only this. There's no modification for my treatment.
Okay, thank you. Yeah.
Other question?
There's just another question from Samuel. He's asking, after a temporary tracheostomy, as described before, intubate under direct vision in ER or on the OR maybe? So I don't know if you can comment on that, and also Dr. Albert Veron, maybe he can comment on the airway management of a patient with a tracheostomy.
Well, it depends on your setting in general. We prefer to do it in the OR because you have everything you need. So when you have a difficult airway, even if it's not in an injury, angio, anything that is difficult, you have all the resources in the OR. So if possible, it's not always possible, depending on your setting, we normally bring the patients to the OR to do that.
Excellent, thank you. Okay, Dr. Collet, thank you very much for presenting the case. It was really interesting, really nice case. Thank you all the panelists for the comments. It was great to hear from you and all your expert opinions. And we'll see each other next week. Bye-bye, thank you.